I've called the House Judiciary Committee.
Detention and commitment of persons with substance use disorder. Just for some brief context, under current law, a person can be detained after an initial evaluation for up to 72 hours under either the Involuntary Treatment Act if a designated mental health professional or DMHP finds that the person meets criteria for detention under the mental health statute, or under the chemical dependency or substance use statutes if a designated chemical dependency specialist finds that the person meets criteria for detention due to alcohol or other drug-related issues. If a person is detained under the Involuntary Treatment Act, the DMHP is required to detain the person to an evaluation and treatment facility, which is defined as any facility that can provide emergency evaluation and treatment and inpatient care to persons suffering from a mental disorder. These facilities are certified by the Department of Social and Health Services, or DSHS, and DSHS contracts with behavioral health organizations to provide these ENT services. DMHPs are required to submit to DSHS what is referred to as a no-bed report when a decision to detain a person is made, but there are no available beds in an evaluation treatment facility, and the individual cannot be served through a single-bed certification or less restrictive alternative. DSHS then takes these reports and shares them with the responsible behavioral health organizations for a variety of purposes, one of which is to determine whether a BHO region has sufficient evaluation treatment capacity. If a person is detained under the chemical dependency statutes, they can be detained to an approved secure detoxification facility or treatment program subject to available beds. Now, beginning April 1st, 2018, mental health and substance use disorder provisions pertaining to involuntary health treatment will be integrated. So substance use disorder commitments will follow the same procedures, rights, requirements as mental health commitments. And designated mental health professionals and designated chemical dependency specialists will be replaced by designated crisis responders who will be authorized to conduct both mental health and substance use disorder evaluations. House Bill 2401 would require the soon-to-be designated crisis responders to submit a no-bed report when a substance use disorder detention decision has been made, but there are no available beds at a secure detoxification facility or approved treatment program. When DSHS receives 60 no-bed reports within any 3-month period, they will be required to suspend all substance use disorder evaluation, detention, and commitment services until an additional 48 secure detox beds, to include at least one 16-bed secure detox facility in Eastern Washington, comes online. Notification from DSHS of the suspension and subsequent resumption of services must be sent out to the behavioral health organizations, designated crisis responders, secure detox facilities, and hospitals. Standards and conditions for these notifications must be established by DSHS. There is an emergency clause in this bill. That concludes my remarks, and I'm happy to respond to any questions.
So, Ingrid, would it be fair to say that this is a bill that's anticipating there might be problems, but because the law hasn't been implemented at all yet, we haven't seen the problem yet because the bill actually hasn't been implemented?
Correct.
Okay.
We don't know because it starts April 1st.
Okay, great. Thank you. I am the prime sponsor on this bill, and I would just tell the committee that I think this is a worthwhile conversation to be having because the problem is theoretical. And the folks who are going to testify in favor of the bill know this. I'm not certain that we really should be trying to address this until we actually have some data on this, but it certainly is worth considering and knowing that this is something we need to keep our eye out on. So I'll be interested to hear the testimony, and with that I think we'll let Representative Valdez serve as vice chair for the first time and call people. Representative Graves, did you have a question?
I actually do. Thank you, Madam Chair. Why the emergency clause?
Well, because folks are anticipating that it would be an emergency right away, that the beds would all fill up. Again, I prime sponsored this bill for dialogue. So, Representative Clippert.
Thank you, Madam Chair. I'm looking at page 5, number sub 3, and 60 reports. Is that 60 reports for a region on one person? What, 60 reports of I'm trying to understand what that means.
Well, Ingrid, correct me if I'm wrong, but it's statewide, so the beds are available statewide. So it's basically 60 times over a 90-day period if there were to be no beds available in the state. That's when it would click in. Am I correct?
Correct. It's 60 beds total.
Yeah, very quick follow-on. And concerning the suspension, it talks about suspension several times in that page 5. If you or anyone else who's testifying on this bill wants to further describe that, I'd love to understand that further.
Okay.
Thank you.
With that, Representative Valdez.
Great, thank you, Madam Chair. Our first 3 speakers will be Shailene Whitaker, Lijah Meseropes, sorry if I mispronounced that, and Eric Penner.
And as people are coming forward, I'm not going to start with a timer here, but based on the number of people we have signed in to testify on bills, you should kind of gauge yourself to 2 or 2.5 minutes, if you could. Shailene, go ahead.
Great, thank you. Representative Jenkins, members of the committee, thank you for hearing House Bill 2401 today. I think this is an important dialogue, as you mentioned, and I'm going to provide some framing comments, and then I'll leave it to the panel who sees patients struggling with substance use disorders every day to talk about what we're expecting to see based on the implementation of what is known as Ricky's Law on April 1st. So, one thing I want to make sure that we're really clear about is that we support the underlying premise of Ricky's Law. We want people to get treatment who can't potentially help themselves in these situations based on their addiction. And we want this law to work. And that's why we put forward this bill, because we have deep concerns that there's not going to be enough capacity in the system for the amount of demand that is going to be generated based on this law. Starting April 1st, we're going to have all of the emergency departments in the state, so about 100 of them, referring patients with substance use disorders who are a serious, imminent threat to themselves or others, or gravely disabled based on their substance use disorder. That's the same standard that exists today for mental health. What we're worried about is that you will hear heartbreaking stories from family members who are going to be coming up here after our panel is done, talking about why they need this law to save their son or daughter or their other family member. And what we are worried about is that this is creating a false hope for those families, that with only 48 beds statewide, that we are going to have demand that completely outstrips capacity. So you'll hear from Dr. Penner about what it's like to look in patients' eyes and tell them, I'm sorry, we can't help you. So the other piece I'd like to talk about is that designated crisis responders will be unable to detain if there is no bed. So the patient will be told that, yes, you potentially meet detention criteria, yet because we don't have space available, we cannot involuntarily detain you and you cannot get help. When I've talked to a couple of hospitals that have in the Spokane area that are really looking at how this law would impact patients that they're seeing, they expect out of their 2 emergency departments to have 3 patients a day referred. So there's one 24-bed facility in Spokane that is going to be online as of April 1st. And 3 patients a day means from Spokane alone that facility would be full. So that leaves, the areas of Wenatchee, Tri-Cities, Yakima, Moses Lake. Where are the patients from those areas going to go? So as I mentioned, we do not think there's going to be enough capacity statewide, but since we're not 100% sure, the bill is a trigger. So it contains a trigger where if we are not, if we are not referring and there's not people needing to be detained under this law, this bill would not kick in. So that's how we've structured it, and I want to let you hear from the real people who are seeing these patients every day.
Go ahead.
Thank you. Good morning, Madam Chair, members of the committee. Thank you for hearing our testimony. My name is Lijah Meseropes. I'm the Chief Nursing Officer at Providence Regional Medical Center, Everett. I've been a nurse for 30 years. Prov Everett is a 530-bed acute care hospital licensed at 530 beds, and our daily census is about that and then some. So we struggle at times of the year with capacity, but I'll get to that in just a moment. Our emergency department is one of the busiest in the state. We have 79 beds in our emergency department and are among the top 1, 2, or 3 emergency departments in the state in terms of volumes. In 2017, we saw about 95,000 patients in our emergency department and about 97,000 the year before. Our concern that with Ricky's Law as it is written is that it really does create a false hope and a false promise for folks that are struggling with substance use disorder and with addiction, in that acute care hospitals are not the best setting for people with substance use disorder and or addiction. We also believe that this diminishes our hospital's ability to care for patients who do require an acute care hospital setting to take care of their multiple medical conditions. Some statistics that I think are concerning that, and why we bring this forward now, well, you know, recognizing that it's a theoretical conversation. Shalene spoke to the Spokane hospitals. I looked at statistics in Everett, and in 2017, we saw average of 4.74 patients a day with a primary diagnosis of substance use disorder. We saw about 1.12 patients on average per day with a primary disorder of overdose, and 4.73 with a primary diagnosis of alcoholism, acute or chronic alcoholism. So the concern is that we will very quickly outstrip the need and the capacity. Today we have anywhere from 70 to 100 patients that are in our hospital that don't require acute medical care, but that don't have a safe disposition to which to be discharged. So we're already struggling from capacity. And then what that means for us in terms of providing daily care for patients is that they arrive in our hospital with a waiting room filled with literally 100 plus patients, and trying to provide care for patients in the lobbies of our emergency departments and admitting patients sometimes to the hallways of our hospital units. So our concern is, again, that we don't have the best facility to provide care for folks struggling with substance use disorder and addiction, and that similarly we place at risk people who do need acute medical care in the setting of the hospital. So with that, I thank you, and we do ask for you to vote yes on House Bill 2401.
Go ahead.
Yeah, thank you, Madam Chair and Committee. And first, I'd like to applaud you for having this discussion, and want to extend an invitation to you or anybody that you would like to come see what it's like in the ER and how bills are affected. So my name is Eric Penner, and I've been a local emergency physician for 15 years. As emergency doctors, we're there 24 hours a day, 7 days a week, nights, holiday, weekends. We're the safety net for all those in need. I'm here to support House Bill 2401. House Bill 2401 will help patients that Ricky's Law was intended to help, as well as to help all our patients that need emergency care. The issue, as I see it, is capacity. Ricky's Law, as written, will worsen the capacity issue we face daily in the ER. And for example, I'll just tell you about my last shift. A couple days ago, my shift started at 5 a.m. We have a 40-bed ER. 24 of those beds were filled by admitted medical patients or patients awaiting psychiatric beds. The first patient I saw had been waiting there for 7 hours and had checked in before midnight, and I had to see them in the hallway. Why the long wait? Well, because all the facilities are currently full. They're at capacity already. We cannot move patients out of the ER to appropriate beds to get the appropriate care. When that happens, people like you, your friends, your family, and community all have to wait in the waiting room longer. Ricky's Law, without modification or more funding, will make that capacity issue worse. With the amount of substance abuse I see daily, 24 beds in Western Washington will not be nearly enough. So guess where these patients stay? They'll stay in the ER, which will make our capacity even worse, making it more difficult to care for everyone else who needs emergent care. This is a very important negative unintended public safety issue for all of us. When people have an emergent condition and have to wait 6 or 7 hours to be seen, they have worse outcomes. Last week, we had someone code in our waiting room because we had long waits. I have to tell patients and families that our medical system is broken, and yes, their loved one needs something, but we can't provide it for them for various reasons. These are often demoralizing conversations for the patients and families, and they're hard. Ricky's Law is written and not fully funded will create the need for me to have more of these discussions. I'll have to say, yes, I know you had to wait 7 hours to be seen and then waited 6 more hours to see the designated crisis responder. And I agree, your child needs substance abuse treatment and you're counting on a treatment bed. But sorry, there are no beds because of lack of funding. House Bill 2401 is a good steps towards mitigating this problem and in the long run helps all patients that Ricky's Law was intended to help. Thank you.
So can I ask, what do you do with patients right now?
with what specific condition?
Chemical dependent, I mean, I'm presuming that under the law, someone who comes in and who needs further treatment, you're required by law to discharge them with a treatment
Yeah, so if
plan,
people come
right?
in,
And not to discharge them if you don't have one.
sure. So if people come in with an addiction problem and they're high and can't make competent decisions, they stay there until they can make a competent decision. And then if they choose to do an inpatient treatment program and one is available, we have a social worker that will talk with them, talk to the treatment facility, look at the insurance and see if they qualify for inpatient treatment. And if they do, then they can go do that. Usually there aren't treatment beds available for them inpatient if a patient chooses to do that. So then they're given outpatient resources to go home with a safety plan and outpatient resources, and it's up to them and the family to make that happen.
Can I add on to that?
Sure.
That we are, there are a couple of our hospitals that have outpatient detox facilities. They have said that they are full, they have wait lists, they have issues with prior authorization, they have issues with just not enough capacity. We have, I don't think as a state, built up some of that voluntary capacity as well that would help patients who do want to seek treatment. So I think there's kind of two different buckets. And I think the other challenge about this law is that the secure detox facilities that are funded without a medical overlay, meaning patients with alcoholism who would be detained under this, or benzodiazepine. They're not going to be able to go to these secure detox facilities because those are patients that are going to need medical monitoring, and that hasn't been funded to allow that in an outpatient non-hospital setting. So those facilities exist today. They are available, but not for involuntarily detained patients because they're not secure detox facilities. So I think there's a funding issue and a type of service issue going on here as well.
Well, on the voluntary treatment, are there things preventing you from adding beds?
So on the voluntary side, I mean, that many of these services can be done in a non-hospital setting. So it's much cheaper to do this in the community. The same with like that's why the secure detox facilities are being stood up in non-hospital settings. I mean, if you look at our similar idea would be around psychiatric beds and how much does that cost. At hospitals, they're costing anywhere from $800 to $2,000 a day, depending on what type of patients you're seeing and how complex those patients are. The secure detox facilities that have been set up currently that don't take patients with medical problems, they're $400 a day. So I think there's a conversation here that needs to be had as well about where are the most appropriate settings. And arguably hospitals, the most expensive setting, not all patients need to be served in those in hospitals. So we are, I think there's a cost-effective way to do it, but there's a missing component in the types of services that we have available.
So my last question, Shalene, so your assertion is, like in Spokane, there'd be 3 people civilly committed for chemical dependency a day.
Yes, that's what based on a pilot and based on looking at their overdose data, that's what they're thinking. And that's 2 out of the 4 hospitals in that area.
Okay. That's interesting. When I talked to DSHS, they couldn't make any.
I think now the law's coming into effect, or it's going to be coming into effect. People are looking at it a lot more closely, and their attention is to it. And so we're getting more information than we had even a year ago.
Yeah, my discussion was a week ago, but thank you. Thank you.
Thank you.
Okay, our next 2 speakers will be Sam Huber and Ian Goodhue.
Go ahead.
Good morning, committee. Thank you for the time. I'm Dr. Sam Huber. I'm a psychiatrist, and it is my privilege to be Chief Medical Officer for Behavioral Health for the Multicare Health System. I'm here today at the request of Ms. Whitaker on behalf of House Bill 2401. As many of you know, we are deeply committed to providing compassionate and high-quality health care for people with mental illnesses and substance use disorders in the communities we serve. But we are concerned about implications for the upcoming changes to the Involuntary Treatment Act, and we request your assistance with contingency planning for likely gaps in service. In the Puget Sound region, Multicare operates 6 acute care hospitals with emergency departments and holds the contract for mobile outreach and crisis responders in Pierce County, who will now be called the DCRs. These DCRs saw hundreds of people in crisis over the past year, and with limited staffing. Based on our current volumes and our estimates from past pilot programs, we anticipate that the crisis team referrals will increase by at least 30%. And we're concerned that with no additional resource, personnel, or funding for the DCRs, that this will result in significant delays for these types of evaluations, impacting all people in mental health crisis. As the people before me said, we're also concerned about the availability of secure detox facilities in our area, in our region. Particularly, and so we're asking for contingencies when secure detox capacity is overwhelmed. What I'm concerned about is that if a bed is not available at a facility, then a DCR will not be able to detain a person in need. And at that point, there's no ability to detain to an alternative setting, and to some degree, no ability to send somebody home. In fact, in good conscience, sending people in such need for involuntary commitment and treatment home may be an EMTALA violation. So this may actually reduce the options that we're able to offer patients and families. Again, we want to help people in need. We absolutely do. But if there are no detox beds to detain to and no way to hold them in the ERs to wait, families and hospital staff could be in a worse position than they are today. So we believe this bill would suspend the law if detox capacity is overwhelmed and motivate additional development of capacity. So I thank you for all of your efforts to assist people in mental health crisis and with substance use disorders. And I hope that this additional monitoring will help apply Ricky's Law safely.
Thank you. Go ahead, Ian.
Thank you, Madam Chair, members of the committee. Ian Goodhue here on behalf of UW Medicine, so representing Harborview Medical Center, Northwest Hospital, UW Medical Center, and Valley Medical Center. I'm here today in support of 2401 because I represent the ER doctors, the psychiatrists, the addiction medicine specialists, registered nurses, nurse practitioners, and frontline social workers at Harborview who support Ricky's Law. They support the concept of providing help for those individuals with acute substance abuse disorder who are a risk to themselves or others or gravely disabled, and that's why they support this particular legislation. It's because these frontline social workers, nurses, and doctors deal with these individuals on a daily basis that they're asking for this mechanism to protect us from the potential, as the chair has pointed out, the potential of running out of secure detox beds. Right now, every day, people with acute substance abuse disorders are brought to the Harborview emergency room. Our medical staff stabilize them, connect them with frontline social workers, and hope that a meaningful connection in the community through treatment settings or through family members who have reached out to try to help their loved ones find treatment settings result in, when they're discharged from the hospital, these individuals getting the help that they need. But those same frontline medical staff are frustrated because this process is often done on a wing and a prayer. This is the current state of affairs before Ricky Law goes into effect. In fact, I even had an emergency room doctor who I represent indicate to me that oftentimes when someone is in the situation, as the doctor next to me described, is in such dire straits that they hope that they can find a medical condition to admit the patient into the hospital so that they're not releasing them right away to an outpatient referral that could take days or weeks. That's because they don't have anywhere to send them right now. So how do we fix this problem? That's exactly what Ricky's Law was intended to do, was to be a solution to this problem, to help those who need help immediately and may not even want it themselves at the time that they're in our hospital emergency rooms. But these same frontline social healthcare workers worry that right now the hope will not be fulfilled for most families and patients. The reason is clear. We have a total, or will have a total, of 48 secure detox beds across the state when the law goes into effect in just 2 counties. 37 of 39 counties will not have secure detox beds to send these patients to once they are committed under the new process. Our frontline medical staff believe that the secure detox facility will quickly run out, leaving most families in the same situation that they find themselves in now. They reach this conclusion before the law even takes effect, even though it's a presumption, because they have experience, because they've been here before. All we have to do is look at the current ITA system to see what this potential problem is. As all of you know all too well, we do not have enough short-term and long-term civil commitment beds in the state. You all have been working on this, this problem, particularly the chair, for several years now. But just a handful of years ago, we dealt with the aborting issue under the ITA system.
Ian, can you wrap up?
Sure. So I'll just cut to the chase. So what's the current ITA situation at Harborview right now, after all the work that you've done on the ITA process? Just last week, we have 66 inpatient involuntary beds at Harborview. We had 14 people that were in single bed certifications in addition to the 66 beds being full. We had 20 patients that were on a waiting list to go to Western, past the time that they should have gone to Western, and we had another 30 patients on med-surg, meaning they had a medical condition that they were going to soon come off of and need to go into the secure inpatient beds. Now, it would be that system that we would need to take in these patients at Harborview to just wait to then go to the secure detox beds. We simply don't have the capacity right now to handle these patients, even though we want to. So, Representative Jenkins, to your question about what are other alternative solutions, why not build more beds? I think we would if we could at Harborview. We simply don't have the physical space to do it there. It happens to be in probably one of the most expensive pieces of property in the state. We do look for alternative solutions like the crisis diversion facility that King County funded with MID funding that the legislature made available. That's 16 beds that we can send individuals to in a voluntary setting.
So Ian,
yes.
It's not quite a wrap up.
Okay.
So sorry, we have 5 other bills we're hearing today.
I'll just conclude by saying we want to work. I hope the problem doesn't occur, but if it does, we wanted to flag it for you. Thank you.
Thank you. Thank you both.
Okay, our next 3 folks to come up will be Lauren Davis, Kyra Dubeck, and Sophia Hall.
Go ahead, Lauren.
Good morning, Madam Chair and members of the committee. My name is Lauren Davis, and I'm testifying in opposition to House Bill 2401. We owe a debt of gratitude to this committee, and particularly to Chair Jenkins, for the work on Ricky's Law. Ricky's Law was named after my best friend, who barely survived our system and now has 5 years in long-term recovery. Since Ricky's Law passed, national news outlets have been full of headlines that read, "Families seek involuntary commitment laws as key tool in saving opioid addicts," and "Support grows for civil commitment among opioid users." I've even received a call from the Delaware Attorney General's office about how they can implement Ricky's Law. As we've waited for implementation, the suffering continues. Just 3 months ago, I sat in a motel room with a loved one as I watched him desperately stabbing himself with a heroin-filled syringe, trying to find a vein. He stood there, covered in his own blood, weeping. "I can't stop," he whimpered. "I can't stop." I sat up beside him all night to monitor his breathing, repeatedly having to violently shake him awake as he started to overdose, as he began to choke in his sleep, gasping for air. And then I did it again, night after night, stayed awake to make sure he didn't stop breathing. Because when someone you love is dying, you don't feel like you have a choice. Yet he refused treatment. Weeks later, he was admitted to the hospital and told that the infection from IV drug use in his wrist was so severe, his lower arm would have to be amputated. Even with this information, he walked out of the hospital against medical advice, 2 IV ports still in his arm. The greatest irony of all this young man sat right here 2 years ago and testified in support of Ricky's Law. He told how the only thing that had ever previously launched him into recovery was the criminal justice system because he needed to be compelled into treatment. He's still out on the streets using, and every day, every single day, I wake up and pray that he lives long enough to be helped by the very legislation he fought for. It's important to remember that DCRs do far more than detain to inpatient beds. They can engage a client in motivational interviewing and refer to an array of crisis services and outpatient services and voluntary inpatient services. It's also noteworthy that Ricky's Law only required 16 beds to be online by April 1st, and will actually have 3 times that many, 48, plus a King County facility of 16 beds opening later this year, plus a youth facility that's already open that takes Ricky's Law patients. This legislation seeks to suspend Ricky's Law. It suggests that if we can't help everyone, we shouldn't help anyone. Hundreds of families in our state have hung their hearts and their hope on Ricky's Law. Please don't take that from us. Thank you.
Thank you. Go ahead.
Good morning, Madam Chair and members of the committee. My name is Kira Dobek, and I'm a constituent of Legislative District 29, and I work in District 33. I am in behavioral health recovery from substance use disorder and have been since July 2013. As a social worker in a behavioral health agency, I encounter substance use disorder daily in my field, and I strongly oppose House Bill 2401. In 2010, I was taken by ambulance and hospitalized because of a drug-induced psychological episode. My boyfriend at the time told staff there about my uncontrollable polysubstance abuse. They released me within 6 hours, and I was using that night, and I wasn't willing to go to treatment. The overdose that I had in July 2013 that threatened to leave me brain dead could have been prevented had somebody intervened. 3 of the hospitals represented here today treated me, and not only when I was an acute polysubstance abuser, they never offered me outpatient or inpatient resources, and they treated me like I was the scum of the earth. Between 2010 and 2013, anyone who was close to me, bosses, roommates, friends, even the owner of a bar suggested I get help. I didn't want help. I was IV using and drinking a 5th of whiskey a day. I was a danger to myself, society, and the hundreds, if not thousands, of times I drank and drove and used too much or wanted to kill myself while under the influence. People die needlessly from substance use disorder. They die because they're released instead of getting critical care that they need. In the 4.5 years that I've been clean, there have been so many funerals, I can't even count them. My peers are dying every day. Narcan is great, and it has the ability to save people in the moment, and I'm sure every staff person in a hospital can recall treating somebody multiple times for overdose, sometimes twice within a 24-hour period. There must be a mechanism to detain, evaluate, and provide comprehensive care. At this point, when somebody contacts me regarding their loved one that is going to die from substance use disorder, I can't help them or give them any direction other than to pray that they get arrested. Ricky's Law provides this provision. I don't ever want to attend another funeral for someone who needs treatment but died because we didn't medically intervene.
Thank you.
Good morning, Madam Chair and members of the committee. Thank you for hearing us today. My name is Sophia Hall. I am testifying in opposition to Senate Bill 6365. My family are automobile dealers in Puyallup. My daughter, Callie Noel, was generous, loving, fun, hard worker, amazing soccer player, incredible daughter, granddaughter, little sister, and a big sister. She was addicted to, you name it, any illicit drug she could find. Last February, Callie had a psychotic break from methamphetamine use. She had been awake for days and was found naked in the woods in Des Moines by the police. She was delusional, telling them that I was hanging dead from a tree. This was after hours of them searching for her in the woods. Callie ended up being transported to a local hospital by police. She was in desperate need of addiction treatment, but Ricky's Law was not yet in effect, and there was no involuntary option. She walked out of the hospital and immediately returned to hardcore drug use. I had no clue where to find her. On September 1st of last year, at the age of 20, Callie died of a cocktail containing 12 different substances in Hawaii. She was found 5 days later and so decomposed I didn't get to bury her. I wasn't even allowed to see her. I have a lock of her hair. Had we been able to hold her against her will last February and have her admitted to addiction treatment, I believe she would be alive today. I am begging you, on behalf of the thousands of parents, please do not allow this to go unnoticed. Let us be the solution. Please don't suspend Ricky's Law. Please let us help our children. They are the ones born of us, the only ones to hear the heartbeats of us moms in the most pure form. Thank you.
Thank you. Are there questions for the panel?